Good afternoon, my name is Kirsten Cunha. I'm a licensed athletic trainer at the University of Florida, and today we will be discussing the post-op rehabilitation plan for type 3 SLAP lesions. Today we will be discussing the anatomy of the shoulder, the purpose of rehabilitation plans. We'll present a case and discuss the goals and exercises to be found in phases 1, 2, and 3. We'll discuss return to play, and we'll also discuss treatment considerations. The shoulder is a ball and socket joint made up of 3 bones: the humerus, the scapula, and the clavicle. The head of your humerus fits into the rounded socket of your shoulder blade. The socket is called the glenoid fossa, and surrounding the edge of the glenoid rim is a strong fibrous tissue called the labrum. The labrum helps deepen the socket and stabilize the shoulder joint. Now, the term SLAP stands for superior labrum anterior to posterior. A SLAP tear occurs at both the anterior and the posterior points of this attachment. The biceps tendon can be involved in this injury. Fortunately, the biceps tendon is not involved in a type 3 SLAP lesion. Typically, patients with type 3 SLAP lesions will only require a simple arthroscopic debridement of the labrum and do not require anatomic repair. This generally means that rehabilitation is more accelerated for these repairs. The intent of a rehabilitation protocol is to provide the clinician with a guideline or a roadmap of the postoperative rehabilitation course for the patient that has undergone arthroscopic debridement of their type 3 SLAP lesion. Now, there are cases in which the patient has another coexisting pathology, such as rotator cuff tears, which may change the rehabilitation plan and make it look a bit more like a Disney World map. Therefore, a rehabilitation protocol is by no means intended to be a substitute for one's clinical decision-making regarding the progression of a patient's post-operative course based on their physical exam/findings, individual progress, and/or the presence of post-operative complications. If a clinician requires assistance in the progression of a post-operative rehab, they should consult with the referring physician. Now let's take a look at a case to try to apply what we've learned. Our patient, Caro, is a 20-year-old modern dancer who specializes in acrobatics. She sustained an isolated type 3 SLAP lesion after falling on her shoulder during an aerial jump. The patient is 1 week post-op for her type 3 SLAP lesion debridement. The surgeon informs you that the patient is ready to participate in a progressive rehab plan. The first phase of the rehabilitation plan lasts from approximately day 1 to day 14. The goals of this phase are to reestablish non-painful range of motion, to minimize atrophy, and to decrease pain and inflammation. The next exercise to be performed are pendulums. These can be performed at home and will be excellent to improve shoulder range of motion in a passive way. Inform the patient to bend at the waist so that their arm is dangling down. They may hold a chair or table for support. Gently, they'll rock their body back and forth from left to right or in a circular motion in order to secondarily move their arm in that motion. There should be no active motion performed with this exercise. Next, we will perform external rotation with an L-bar. Lie on your back with the involved arm at 45 degrees from the body and the elbow bent at 90 degrees. Grip the L-bar in the hand of the involved arm and keep the elbow in a flexed position. Using the uninvolved arm, we'll push the involved arm to external rotation. This is an example of active assisted range of motion and will help to complete our goal of achieving full non-painful range of motion. Again, coach your patient not to use their involved arm in order to move. All motion during this exercise should come from the uninvolved side. Criteria to progress to stage 2 or phase 2 includes full passive range of motion, minimal pain and tenderness in the area, and approximately a 4 out of 5 manual muscle test in motions of internal, external rotation, and flexion. Once in phase 2, which should occur during weeks 2 through 4, the goal will be to enhance muscular strength, normalize arthrokinematics, and improve the neuromuscular control of the shoulder. An exercise to consider including in your phase 2 would be push-ups with a plus against a wall. You'll correct the patient's posture and then instruct them to perform a push-up. You'll then have them protract in order to engage their scapulothoracic musculature and improve scapulothoracic stabilization. In order to improve the patient's shoulder arthrokinematics, I will have her perform scaption. I will place her in the position of around 90 degrees of shoulder flexion, coupled with 45 degrees of abduction. I will have her perform scaption up to 90 degrees of shoulder flexion in order to improve shoulder arthrokinematics. We'll want to ensure that she's engaging her scapular musculature by pinching her scapulae together. We'll want to ensure that she is maintaining a proper posture with her core engaged. Biofeedback could be an appropriate mechanism here to ensure that she is engaging the proper musculature. Phase 3 is deemed appropriate when the patient exhibits full, non-painful, active and passive range of motion, there is no pain or tenderness at all, and the strength is approximately 70% when compared to the contralateral side with a handheld dynamometer or through manual muscle testing. The goals of Phase 3 are to enhance strength, power, and endurance, enhance neuromuscular control, and to begin gentle sport-specific preparation activities. To enhance neuromuscular control and stabilization of the shoulder joint, I will perform rhythmic stabilization. I will first move the patient passively through the motion that I will be placing her in order for her to feel. I will then cue her to try to glue her shoulder blade to the table and feel her humerus being sucked into her glenoid. I will then, with minimal resistance, hit her hand while she is trying to go through the motion herself. I will continue to cue her to maintain as much stabilization as possible, and will lighten my resistance based on what I can see her capabilities to be. Our next exercise is focused on performing advanced strengthening techniques. Utilizing tubing, we'll perform internal and external rotation at 0 degrees. First, I will have the patient place a bolster under her elbow in order to support her comfort. I will adjust her posture so as to ensure that she is maintaining proper alignment. I will instruct her to gauge her core, and I will guide her through the motion. Be sure to ask your patient whether or not they may need adjustments in the resistance. They may walk closer to the stabilization point of the resistance band in order to alleviate it, or you can switch out the band for a lighter band. Additionally, this exercise can be performed at home by utilizing a towel, a TheraBand, or a t-shirt, tying a knot at the end of it, and closing the knot into a door frame, and complete the exercise as initially instructed. Phase 4 occurs during week 6 and beyond. The purpose and goal of Stage 4 is to progressively increase activities in order to prepare the patient for their full functional return to activity. Some considerations to your treatment plan. The patient may have personal goals that differ from actually returning to participation. It is important to debrief with your patient prior to initiating this rehabilitation protocol to ensure that your goals and the individual's goals match. Additionally, there might be some psychological impediments to healing. There is imposter syndrome or fear avoidance, and these capacities might restrict your patient from progressing as quickly as you would like. Therefore, it's important to monitor your patient's psychological well-being throughout the entire injury process as well as the healing process.
You're going to want to go right there, I think, because... Oh, I was...